Having me. Like Erin said, my name's Katie. I was a former pediatric hemonc fellow here, and then I stayed for an additional year to do a palliative care fellowship, and now I'm back in the hemonc department. So this project really combines both of my worlds of hemonc or hematology and palliative care. So I'm going to talk about my pilot project today, which is titled Patient, Caregiver, and Healthcare Provider Perspectives on Barriers to Pharmacologic and Non-Pharmacologic Therapies for Pain and Sickle Cell Disease. So pain is the main cause of poor quality of life and hospital admissions among patients with sickle cell disease. And pain in sickle cell disease is very complex. So there's acute pain, which is focal. It may last for hours to days to weeks, often not longer. It can be triggered by things like stress, changes in weather, infection, increased activity. And that's really a typical VOC, is an acute type of sickle cell pain. When there's multiple episodes of VOC or multiple types of pain, that can sometimes lead to a more chronic pain, which is more generalized. Patients may describe hyperalgesia, allodynia, and that occurs due to this heightened hypersensitivity to a pain stimulus. So patients can have peripheral and central sensitization leading to this chronic pain, which by definition lasts 3 months or longer. And things that could affect chronic pain also include stress, just like with acute pain. In addition to that, it's more mood disorders, sleep disorders. I wanted to talk about the American Society of Hematology guidelines for the treatment of acute and chronic pain in sickle cell disease. So in terms of acute pain management, ASH recommends opioid therapy and a short course of NSAIDs. Subanesthetic ketamine infusion is also recommended for pain that's refractory to opioids alone. And by adding this, it allows us to come down on the total opioids and is really an adjunctive treatment and can help for pain, again, refractory just to opioids. In addition to that, it also recommends integrative therapies such as massage, yoga, and guided audiovisual relaxation techniques as complementary therapies in addition to pharmacologic management. In terms of chronic pain management, this actually does not include opioids as one of the treatments, but cognitive behavioral therapy is really the gold standard. In addition to that, massage therapy and acupuncture have been outlined as being management for chronic pain. And then in addition to that, ASH notes that for adults with sickle cell disease, SNRIs, TCAs, and gabapentinoids are helpful. And in the pediatric population, those are also pharmacologic agents that we use for chronic pain as well. So there's definitely increasing evidence for the use of non-opioid interventions in sickle cell disease pain. Definitely in both acute and chronic, but for chronic, opioids are not part of the therapy for chronic pain management. So definitely CBT and other integrative therapies are really most helpful for that. And there is a critical gap in understanding the factors that influence the use of these interventions. So prior studies have rarely assessed patient, caregiver, and healthcare provider perspectives on these therapies. So this study is particularly focusing on adolescents and young adults with sickle cell disease, and the reason for that is because compared to their younger counterparts, this patient population has higher rates of acute and chronic pain, which lead to increased hospital admissions, overall increased morbidity, and a poorer quality of life. So there are two aims for this study. The first aim is to first examine the usage of pharmacologic and non-pharmacologic therapies among AYAs with sickle cell disease receiving care at Nemours. So to do this, we're using the Sickle Cell Knowledge Base, which is a custom platform that outlines all data for our sickle cell patients, as well as the electronic medical record to examine the proportion of AYAs with sickle cell disease who are between the ages of 13 to 21 at the time of 2016 to 2021 who received care at Nemours and were prescribed pharmacologic and non-pharmacologic interventions for management of pain and sickle cell disease. And we hypothesize that it's expected then that fewer than half of AYAs will have utilized non-opioid and non-pharm therapies for sickle cell disease pain. And then aim 2 is to identify patient, caregiver, and healthcare provider reported barriers to farm and non-farm interventions for pain and sickle cell disease. And to do this, we planned on using semi-structured qualitative interviews with AYAs with sickle cell disease between the ages of 13 to 21 who are currently treated at Nemours and have had hospital admissions for vaso-occlusive crises and or a diagnosis of chronic pain, looking in the past 6 years or so, along with their caregivers and healthcare providers to assess perspectives on various farm and non-farm therapies for acute and chronic sickle cell disease pain. And we hypothesize that patient, caregiver, provider, healthcare system, and broader societal barriers to utilization of farm and non-farm sickle cell disease pain management interventions will be identified in doing these interviews. So the impact is to first gather baseline data on what our current use of farm and non-farm therapies are for management in sickle cell disease pain. And ultimately, through the use of the qualitative interviews, we hope to learn about knowledge of acute and chronic pain and interventions for treatment, as well as barriers to their use, and ultimately aim to maximize pain control, improve quality of life, and increase self-efficacy in pain management. And the results of this study will hopefully provide the basis for partnering with AYAs and caregivers in the creation of educational and shared decision-making tools for AYAs and caregivers, and thereby increase the knowledge of and utilization of non-opioid therapies. And long-term, we hope to validate and disseminate co-created non-opioid pain management educational and intervention tools to increase, again, the utilization of these non-opioid therapies and really overall improve the knowledge surrounding acute and chronic pain from a patient, caregiver, and healthcare provider level. This is a timeline of my project. Currently for AIM 1 and 2, I have finalized the protocol, have gotten IRB approval. For AIM 1, I'm in the process of abstracting data, and for AIM 2, we have just started recruitment and have had a couple of interviews so far. That's all.